Anyway, good afternoon, everyone. Thank you so much for the opportunity to discuss with you some cases in what's called the Grand Round or Arab Thyroid Association Grand Round. It's a great pleasure, actually, to participate in this excellent conference. And I'm especially honored to have a number of distinguished panelists with us today. It's a great pleasure and honor to have Professor Naifa Busaidi from MD Anderson in USA, Professor Christine Pollard from UK, University of Birmingham, and Dr. Shada Samarkandi, Associate Professor from King Abdulaziz University. I will share my slides and then we will start the session. I just want to make sure that the panelists are with me. I think Christine is here, correct? Hi, Christine. Good to see you. Dr. Busaidi is there? Naifa? Dr. Naifa?
علي
أيوة معك.
It's Naifa.
Excellent. So again, it's a great pleasure to have this distinguished panel. And I'm very honored to have them, and we are very excited about this session. The only thing I must say that I have a lot of echo, so I hear my voice 3 times. So I hope our tech people will take care of that. So we are going to make this session interactive. And we are going to use this program, PreFox application, so everybody can participate. So to get into the session, you need either to put in your browser freefox.app and then enter the ID of the session, or just scan this code and you will be there. I'm going to give a few seconds for this. And you will have the opportunity to join later on because I kept the code on essentially all the slides that your participation will be included in. All right, so we have actually 4 cases today, and we have enough time. Hopefully, we can cover those cases. But to start with, let's test the program. So this is a slide just to test that the polling is working. You are an endocrinologist, thyroid surgeon, ENT surgeon, internist, and so far. So please choose your specialty. For every voting slide, we have 10 seconds. So let's see what are the results here. So the majority are actually endocrinologists, fortunately. We don't have other specialties, but we have a good number of residents, and you are practicing in one of those countries. So please go ahead and choose. Okay, so you can see that we have people from different countries here in the Gulf, and I just want to make sure about the technical part. So is the transmission good? Please go ahead and tell me if it's good. No, sound can be improved, or pictures are not clear. So sound can be improved. I think, again, this is for our technical people, and in 11%, the transmission is not good. So hopefully we can improve on this. All right, so with that, we'll go to the first case, and it is a short case of a 52-year-old man who was admitted for transsphenoidal surgery of 1.5 by 2.4 centimeter pituitary macroadenoma. The pre-operative anesthesia evaluation reported that he had palpitation, sweating, heat intolerance, increased sweating, weight loss for 1.5 years. He checked his TSH and it was normal at 2.1. So he cleared him for surgery. And then, just as usual, the night before the patient is taken to OR, next day, end of the day at 5 p.m., we were consulted to see him to take care of his hormones, specifically the dexamethasone and the glucocorticoid replacement. So he was going next day for transsphenoidal surgery. We went there, took history, and it is, as just mentioned, he also reported some frontal headache, tiredness, low mood, and anxiety. And his past medical history is only significant for closure of arterial septal defect at age 25. He's now 52.
We lost internet on Dr. Ali's side. So do we have Dr. Hassa? Okay. Dr. Hassa Buharoun is an endocrine consultant at SKMC Endocrine Fellowship at Imperial UK Neuroendocrine Tumor Fellowship at Royal Free Hospital UK Thyroid. She's a thyroid cancer leader at SKMC. And I think while we wait to try to get Dr. Zaharani back, she's going to talk to us about papillary thyroid cancer and hemodialysis. And then we'll get Dr. Zaharani back.
Assalamu alaikum. I'm very happy to be here today to present my case actually in front of the expertise and also in front of one of my leaders, Dr. Khalid Dahmani. So I'm still young in the field, so hopefully this will be an informative case. And I think this is the first case that we had at our hospital. So I'm presenting a case of papillary thyroid cancer and hemodialysis patient. I will be talking about the case and we'll do some discussion, and we're talking about the management of papillary thyroid cancer and end-stage renal disease with some literature review. So we did have a patient of 54-year-old type 2 diabetes, hypertensive, end-stage renal disease on dialysis for transplant. Actually, he has been referred as usual to our clinic through pre-transplant assessment. They found that incidentally he had thyroid nodule. Thyroid ultrasound showed that he had big right thyroid nodule of 5.2 centimeter and also other small nodules on the right and left. So our concern was of the big one, and we can actually remind ourselves with the Thyroid scoring of the thyroid nodule through the ultrasound. And we can see from the pictures here that according to the score, it's around Thyroid 3. And this is due to the echogenicity and also due to the composition. So because of the size of the nodule and also because of the history of the patient, we actually considered this as mild to moderate suspicious nodule. On further history, the patient has no compressive symptoms. He gets some fluctuating mild hoarseness of voice, no family history of thyroid cancer, no symptoms of hypo or hyperthyroidism, normal thyroid function biochemically. So we decided that we'll do FNA for him, and FNA showed that he got malignant papillary thyroid carcinoma, Bethesda system scoring of 6. So according to that, we discussed the case at our thyroid MD team, and we were deciding with actually discussing with the surgeon what type of surgery that we need to go for. Patient was preferring chemothyroidectomy, but we thought that because the patient will be at least intermediate risk of recurrence, he will benefit or he will require radioiodine later on, being a candidate for renal transplant. So we decide that we'll go for total thyroidectomy. So he had total thyroidectomy with central neck dissection, discharged home on levothyroxine on 125 microgram daily. He was doing very well. And on the follow-up, we got the pathology details, which showed actually 5 centimeter tumor in the right lobe, unifocal, a classical type of pathology, no lymphatic invasion, perineural invasion, or extrathyroidal extension, and staged as BT3A and 0MX. So as a risk stratification and as a follow-up management that we do at our clinic, we need to decide about the TSH suppression, thyroglobulin level, thyroid ultrasound, post-op at least 2 to 3 months, and then we can assess the risk and decide about radioiodine. So he had thyroid ultrasound 3 months later, which showed actually no residual disease, clear, and his thyroglobulin was undetectable, so he got excellent radiological and biochemical response. So according to the risk stratification and according to the result that we got, actually he is between intermediate and high risk because of the size of the tumor, and also considering his history of transplant later on. So we did discuss the case again at the thyroid and MDT, and we decided that he needed radioiodine actually. So the challenge in this case was to decide about the dose of the radioiodine, especially with hemodialysis, and how we will organize that. So after actually a lot of literature review from our nuclear actually team and our discussion at the MDT, we decided that he will go for 50 millicurie. And we did decide a plan with the nephrology team regarding the dialysis days. So we did a plan for long admission on dialysis day. We will go through TSH stimulation on the same day, then dialysis in the following day, and we'll dose him with radioiodine 50 millicurie, then dialysis, then discharge. So that was the plan from our team. But then the patient wanted to postpone the ablation until he's back from his country. And then I was following him to assess him and to do the dynamic risk assessment. And he was completely fine with excellent response. We did discuss with the patient the plan, and he's agreed on it. So what's happened during the radioiodine preparation? We used to give actually the thyrotropin for stimulation, first dose first day of the week. Then we need to decide if he needs the second dose or not. So he received the first dose. Then he came for the result to decide if we need to give the second dose or not. So after the first dose of thyrotropin, his TSH was more than 200. We discussed with the nuclear medicine, and we decided that he does not need a second dose. Then we admit him for ablation. He received the ablation, and after day 1 after ablation, he was doing well. He had a hemodialysis session. Then later on, for like 48, 72 hours, he got the second session of hemodialysis, and he was completely fine. He had whole body scan before discharge or on day of discharge, which showed actually some uptake on the sternum, and we did discuss it with our nuclear consultant, and we can see here the uptake at the sternal area here, retrosternal nodule. We were worried about that initially. That's why we did decide we'll do CT chest. CT chest was fine, does not show any focal, lytic, or sclerotic lesion at the sternum. So we discharged him safely. So what was the challenges in this case? We know that radioiodine is most effective adjuvant treatment after thyroidectomy for certain well-differentiated thyroid cancer to reduce risk of recurrence. So the issue with the end-stage renal disease on hemodialysis, we know that the excretion of the iodine will be a concern. So it's really important to decide about the hemodialysis session and to monitor that closely. And as we know, there is no clear recommendation regarding radioiodine ablation in hemodialysis patient. So that's why it was very important to balance between the uptake of the thyroid cell for the radioiodine and also to minimize the extrathyroidal dose excretion and also to maintain the safety of the excretion from the body. That's why it's need a multidisciplinary approach, it's need a lot of organization, and we need to be very careful with those patients. So what we found in the literature, there is a few, it's not few, but there is some cases in the literature that we can see here. The doses were different, starting from 50, and some of them went up to 250 millicurie, which is also high doses. And they have a different time planning for the hemodialysis. So I think it depends mainly on the patient clinical status, if he's overloaded or not, and also on radiation excretion to decide about the day of dialysis. And here we can see there is a graph which actually showed a case, and it showed the difference between the iodine excretion and normal renal function, and also the difference between the dialysis at 24-hour in the red line here and dialysis at 48-hour. So they did try to achieve the normal excretion rate. So what we learned from this case, scheduling of hemodialysis is important when administering radioactive iodine. A treatment of thyroid cancer with radioiodine in patients with end-stage renal disease require multidisciplinary approach, coordinating dialysis, nuclear medicine, and endocrinologist care. Balancing ideal dosage of iodine and timing of dialysis is to ensure the maximal thyroidal uptake and minimal extrathyroidal concentration is necessary. And then I just want to thank our team from SKMC, who's really did hard work to actually make this management successful. Thank you.
Assalamu alaikum. Very nice.
Yes, I think this was very good. Naif, I have comment on treatment with radioactive iodine in hemodialysis.
Yes, I just wanted to tell Dr. Hissa that that was very nice presentation, first of all, and nice explanation. I have a few questions and a couple of challenges, okay? So I think, you know, there was everything that was done is within guidelines and beyond, and you taught us a few things, right? But it depends, you know, when somebody, he has a lot of comorbidities, this patient, right? And is going for a renal transplant. So when we think about, it depends on the program of renal transplantation. At the time that a thyroid nodule was noted, the question, it was a Thyroid 3, 5.2 centimeters, right? Like you said, there was a suspicion that it was cancer. But do we want to know it's cancer, right? I'm just challenging from the beginning. The reason I'm asking that is once you have cancer, a lot of the renal transplant programs, and I don't know how it works here, but will not take you if you have cancer, right? And you have to be 5 years disease-free from cancer. Now, we know this thyroid cancer patient is probably going to do well. You did everything you could to prevent it. Yeah. But just something to think about, you know, because this is a case where you really want multidisciplinary care. Talk to the nephrologist, right, which I'm sure you did. Talk to the whole group, that the transplant team, what if we never biopsy this to know that it's thyroid cancer? Because we're calling it a Thyroid 3, so we don't know for sure that it's cancer, right? And if we don't biopsy it, will they undergo the renal transplant now, right? And then what would happen when they go on immunosuppressives? Would that change the thyroid cancer? There's a lot to think about here, right? Which you were pointing out that you were worried about. So let's say now we biopsy, we know it's papillary thyroid cancer. By doing surgery and radioactive iodine, we're also delaying the renal transplant, right? So all this discussions beforehand would have been important. I just wanted to point it out. I know you did all that, but the things that were going through my mind at the time. Because this renal transplant potentially will save, right, his life. So once we did the surgery, can we call him cancer-free? Like, what if we decided not to do radioactive iodine? I mean, by the guidelines, he's intermediate risk, radioactive iodine makes sense, so we do the total thyroidectomy. But if ahead of time we said, okay, we're delaying the transplant, we'll do the surgery, I won't be able to use the thyroid globulin to say I'm cancer-free, but I can use ultrasound. One thing to think about, if they didn't need to wait the 5 years out, was do I just do a lobectomy, let them go for the renal transplant? But I don't know that that would have been enough. I don't know what the rules are here for renal transplant, but just something to think about. The other thing is hemodialysis with radioactive iodine, like you said, is very complicated.
Yeah.
You guys did a really cool thing. You only gave one thyrogen. I actually haven't seen that, but I thought that was really cool. And giving that, and then your timing was 24 hours after the first iodine? After the first thyrogen?
It was on the same day, and then, 24 hours.
24 hours, yeah.
Yeah.
Okay. So, and you managed to clear him and get him out,
Yeah.
right? That's not always easy,
Was-
but I like that you chose a low, like 50 millicuries instead of the 100
Yeah.
that's in the literature, right? So it clears faster. So those were my only comments. I thought it was really good, but it's important if you ever have a patient like that, because it's so complicated, the multidisciplinary care with the transplant team, the nephrologist, the dialysis team, the nuclear medicine. I'm sure it took a lot of your time, right?
Yeah.
It stops clinic.
Yes.
So,
Skin?
Hi, can you hear me?
Yes.
So I just wanted to ask Naifa then, because you said, could you have done a hemithyroidectomy and then gone with the transplant? But your hemithyroidectomy would have shown that he has a 5 centimeter PTC. So surely that doesn't, put him on the eligible list, because he would still have had to wait 5 years. Or have I got that wrong?
the rules here, what are the rules about transplant? Does he have to wait 5 years? I mean, for thyroid cancer, to me, 5 years doesn't even make sense, right? But transplant rules are transplant rules. So the problem, yeah, and so if that conversation happened before and they agreed that if I can call them cancer-free, even at that 6 months, right, or before, then, but I don't know the rules here. Some, in the States, they're very strict about things like that. And so that's why I was saying before I even put a needle to biopsy, I would have had that conversation. Because right now we don't know it's cancer, right? I'm not God. So if you want to go forward with this transplant and they're going to have to wait 5 years, I would argue, let me watch this nodule and go for the transplant, right? We're still taking a chance. I'm just saying that's one way to think about it. I'm not saying it's the right answer. If they didn't have compressive symptoms, and then, but I'd have to worry about immunosuppression. Right, but we've never proven, we don't have enough cases to prove that the immunosuppression really would have caused a problem. So I don't know.
No, I agree. I think possibly in the UK what we would have done is, and we do get a number of these cases where we say, you know what, just go ahead and transplant this patient, and we will then deal with it, we'll monitor the nodule.
Actually,
But I think that's what you're saying too.
Like from transplant team, there was like no specific time, to be honest, like to decide when they will do the transplant. They just, because we have a lot of issues which can contribute on the timing of the transplant, especially if the patient doesn't have insurance, or the insurance, it will be difficult to get a transplant on expected time, for example. It depends. But the most important thing, it just, we used to take all the patient, the transplant patient, and treat them as an aggressive case, actually, to be honest. Maybe in some cases we will not do, for example, FNA, but with transplant patient we usually do. In some cases, maybe.
It's small. We have lots of cases, and I think this is a very interesting case. We, in our practice, we try to clear them up. Bimana, we send them to surgery quickly. If they need radioactive iodine, we give them radioactive iodine, and then we clear them for the nephrologist to transplant them. I don't think thyroid cancer carries, and I think this is not evidence-based, but knowing the behavior of thyroid cancer, I don't think it's affected so much by immunotherapy or immunosuppression, basically. God knows, but I'm not sure if thyroid cancer is really affected by immunosuppression of renal transplant or other type of transplant.
I don't think, like Naifa says, we have enough data on that.
Correct. Correct. But so let's move because time is moving. So I think you have already seen this slide. This is a young man or a middle-aged man who was admitted for pituitary surgery, and he has some symptoms such as the hyperthyroidism. However, his TSH is normal. Then we were consulted to again take care of his perioperative hormonal management. Basically, this is his history. I don't know where I got disconnected, but we'll just go over this quickly. And then his physical examination showed a tachycardia, wide pulse pressure. He has diffuse goiter, and he has systolic murmur of the aortic area. This is his lab. Prolactin was normal. IGF-1 was high at 347 with the normal for age and sex, up to 210. Normal LH-FSH. Testosterone was also high at 41.8. This is the normal. Cortisol was normal, and ACTH was normal. So I think I have this question for the audience and for a brief discussion. Does this patient have acromegaly? You have seen his lab, and I want just to show it one more time for people who may not have seen it. So the IGF-1 is almost twice the upper limit of normal, 1.5 the upper limit of normal, and also testosterone is high. But the question, does he have acromegaly? Does he have a Hook effect of microprolactinoma? His symptoms are due to ASD that he had in the past, or you need further investigation. Just give a few seconds. I see that the voting is moving. All right, so this is what we have. So I think most people need further investigation now. Christine, what do you think? You had enough information so far.
I would like a glucose tolerance test on this patient.
So you want to rule out acromegaly or rule it in? Naifa, I know that you don't deal with pituitary. Yeah, go ahead.
I'd like to know his free T4 and free T3 as well, please.
Okay, fine. Naifa, what would you like to have?
Yeah, I agree. I want a free T4. I want same as Christine. I don't have anything necessarily to add.
Fine. This is the glucose tolerance test. And you can see the growth hormone and the blood sugar at different times. So the lowest was 1.02 with blood. He had more or less diabetes. Would you like to interpret this, Christine?
So I don't know what cutoffs you use, but we would be suspicious in our labs.
Yeah, we use unit per liter, I believe. And we have the same impression that this did not suppress fully.
It's not sufficient suppression, no.
No sufficient suppression, exactly. Now, for the Hook effect, we diluted prolactin. He has no Hook effect. And for his ASD, we did echo, and it showed normal cardiac function. Do we still need further investigations? Christine?
Do we have his free T3 and free T4?
All right, so this is his TSH, if you remember. We repeated it one more time, and this time 6.5. But as you is he hypothyroid?
I don't know. His free T3 and free T4.
He has hyperthyroid symptoms. This is his FT4. So his FT4 was 76, and the upper limit of normal in our lab is up to 22. And his T3 is 5.7. So maybe you can comment, Christine, on what you think is the diagnosis.
Well, so the diagnosis is of an inappropriately non-suppressed TSH with raised T3 and T4. And so my plan of investigation for this, like in any patient, would be, is this due to an assay interference? Having ruled out that there's nothing else going on, no medication that interferes with this, things like biotin, the certain medications that can interfere, intercurrent illness can interfere. But I would then first check that this is not a laboratory issue are the antibodies to T3 and T4, do a dilution, and do all those investigations, determine his thyroid function on multiple labs. I would then also probably at baseline do an alpha subunit and check an SHBG.
Naita, you have any additional suggestions?
No, I agree completely that, you know, he has hyperthyroid symptoms, but you always have to check, right? Because it could still, because a lot of patients have those symptoms and they're so, you know, they don't necessarily fit with hyperthyroidism. So you need the alpha subunit and the SHBG.
Fair enough. Okay. So remember the history of this patient, he has pituitary tumor. And we had also some hints from his initial lab here. If you look at the initial lab, the testosterone was for us to some extent an interesting phenomenon because this is total testosterone. And the patient has symptoms such of hyperthyroidism. He has pituitary tumor and he has high FT4, quite high, higher than you would normally see with interference with antibodies. So for us, although the consideration here will be drug effects, will be thyroid hormone resistance, will be, of course, TSH reducing adenoma, but I think in the context of all of this, we thought that this patient has TSH-OMA. Would you agree, Christine?
Yeah, so I think, like you say, his testosterone is probably high because he's got high SHBG. And, you know, I think the most likely diagnosis here is one of the TSH-OMA, but I would probably like to confirm that with a TRH test.
Fine. The only thing that did not fit very well is TSH-OMA is usually an isolated hormone. I mean, isolated tumor. Usually you don't get combined hormonal effect. I mean, the fact that he's probably also secreting growth hormone was a bit unusual. But let me show you his MRI at this time. This is his MRI. And you can see clearly that this patient has macroadenoma. It's almost close to the chiasma. You can see after contrast, this is T1 weighted image after contrast, their extension in the cavernous sinus. And this is just the sagittal view here. And this is basically the report, 15 by 24 by 14 millimeter pituitary adenoma, nothing else. And the question here, if you believe me that this is we did not actually do the TRH stimulation test. We felt that there's enough data to make that diagnosis the case. So if you believe in that, how would you manage this patient? And again, this is for the audience. Would you send him for transsphenoidal surgery? I just showed you his MRI. Would you put him on antithyroid medication, then transsphenoidal surgery? Would you give him radioactive iodine, then transsphenoidal surgery? Or would you do something else? Let's see how our audience think about this. Okay, so let's see their choice. So most people want to start him on antithyroid medication, then send him for transsphenoidal surgery. Some would send him directly to transsphenoidal surgery. Nobody would give radioactive iodine, unfortunately. And around 1/3 of our audience would send this, would like to know more or would like to do something else. Naifa, what would you do?
I think the people who said something else maybe wanted beta blockade, and you know what I mean? Like there are other things you would do. His pulse is 92. So yeah, I mean, I think, you know, I obviously would have talked to my neurosurgeon. Again, the theme is multidisciplinary, right? To make sure that they understood the situation, what was going on, and anesthesia, and that they thought it was resectable, which it looks like it is, but we would have them look at the whole MRI. And then, yeah, block the patient and make sure clinically they're stable to go to surgery. And also, looking back in the history, once you got the labs, you know, sometimes our fellows do the history or we do the history and we're in a rush. Looking back, were there any acromegalic symptoms?
No, he was not acromegaloid.
That makes sense, okay.
Christine, what would you do? Which of those would you choose?
I'd also go for something else, probably.
Okay.
Like NIFA, I would discuss with the multidisciplinary team, because that looks a little bit close to the chiasm to me, but I'm not a pituitary doctor, so I need advice from pituitary experts. I think somatostatin analogs are good here in shrinking the tumor preoperatively. Have I never started anyone on anti-thyroid drugs? No, I have indeed. But so the risk from starting anti-thyroid drugs is actually that you can get a growth in the size of the pituitary tumor. And like NIFA, I would also beta block it. But I think a somatostatin analog, if you want to achieve preoperative tumor shrinkage and therefore better result from pituitary surgery, is a good option.
So I'll tell you what we did. We looked at this MRI. A significant portion of the tumor is in the left cavernous side. So if you have a very good surgeon, he would probably remove this segment, this portion, but will leave a significant part in the cavernous sides. And therefore, we felt that somatostatin analogs is the right way to go at this time. And I'll show you what happens. And just to ensure that he has enough somatostatin receptors, this is gallium-68 PET. And you can see the tumor is lightening up very avidly. So that even reassured us that when we give him octreotide or lanreotide, he will show response. And that was the case. He was started on octreotide, initially 20 milligram, and then we increased 30 milligram monthly. We needed later on to add methimazole. I'll show you that. So we started him here. You remember his FT4 was 76. We started octreotide. He immediately, within a few weeks, dipped down to 37. But then on follow-up, he started to go up. So I started him on methimazole along with octreotide. And you can see that his FT4 normalized. Then methimazole dose was 10 milligram. Although there was a period when he actually was not compliant, he lost that. So he's been on this from 2022 to 2024. And this is the whole panel. You can see that the FT4 went down, the total T4 went down. TSH has some relationship with FT4. So when it went down, when the FT4 went down, the TSH went up. But we were not concerned about that. We wanted actually to maintain euthyroidism. Now, more importantly is actually his tumor. You can see his tumor has shrunken big time from around 15 millimeter in this dimension to 9.1 millimeter. And you can see obviously that there is clear shrinkage of the tumor just on octreotide and methimazole. The patient did not want surgery. He felt that this is a big relief. You can see the space between the chiasma and the tumor became quite safe. And that's basically this case. If you have any further comments.
What happened to his IGF-1?
His IGF, that's a very excellent question. And we thought that we treated both of them. His IGF-1 normalized completely with octreotide, whether he has acromegaly, and we took care of both of them with octreotide. Even his testosterone, when we, everything normalized. Yeah, everything normalized with the treatment. Even his testosterone, when his hyperthyroidism came down, normalized, and his free testosterone to start with was normal from the beginning. So that's this case. If you have any further comments on it, or we can proceed to the next one. Naifa, any comments?
I just want to make a quick comment about the PET, the gallium PET, because pituitary tumors and the normal pituitary itself has the somatostatin receptors. So especially in places, if you're in a place where you don't have as much money or access to that gallium PET, it would have lit up with the pituitary. But I think what Dr. Zahrani was pointing out is that this also extends, right? So that it would have been helpful. But if you didn't have the gallium PET, you still could have gone through with the therapy, right?
Correct. I think the TSH-omas are almost always somatostatin receptor rich. But here we have the luxury of doing this, and actually, although the normal pituitary will light up, but in his case, the tumor lights up. We could clearly see it on a cross-sectional. I didn't bring a lot of his tumor is extending into the cavernous sinus. You can see it actually in this image here. You can see that this is corresponding to the tumor. All right.
Two more
Yes,
final
Christine?
comments. So in my experience, the long-acting somatostatin analogs are better here than short-acting. And in particular, with regards to, I mean, we know that anyway, but side effects are often intolerable for patients. So, but I also think they work better. And then Mark Gunnell has some very nice data using methionine PET actually, specifically for TSH tumors. But of course, you know, that's highly specialized and expensive. So I think this has been managed the way we would manage it. So yes, very nice case. Thank you.
Thank you so much. Actually, I started to talk to him about surgery at this time because you have to think about long-term control of this. He's been on for 2 years on octreotide, the risk of gallstones, and also I think surgery now will be much easier in a good hand. We're not pushing too much, but I start to talk to him about long-term control of his tumor by doing transstenoidal surgery. That now most of this cavernous sinus component shrank, and probably a good surgeon will be able to take most of it, if not all of it.
Yeah.
All right. For the sake of time, let's move to the third case. And again, it's my pleasure to present my colleague, Dr. Shada Samarkandi, who's an associate professor at King Abdulaziz University Hospital and an expert in thyroid diseases. We share a number of patients, and I think it's a pleasure to have her today to present a case that's quite interesting. Go ahead, Shada. Do you have the control, or should I move the slides for you? Our technical staff, if you can. Actually, I will move the slides for you if you like.
Okay, thank you, Dr. Ali, for the introduction, and welcome everybody here for this thyroid friend round. I have this case for an interesting young boy who was a 13-year-old boy, previously healthy, who was admitted under pediatrics as a case of chronic cough and shortness of breath for further investigations. And the patient had history of productive cough for 6 months, requiring multiple ER visits, not improving with bronchodilator nor multiple courses of antibiotics. These symptoms were also associated with on and off hoarseness, weight loss, and loss of appetite. He does not have any family histories of malignancies. Other symptoms were unremarkable. On examination, he was virally stable, afebrile, maintaining saturation in room air, but he had an audible stridor. By neck exam, he had palpable mobile small lymph node in level 2 bilaterally, no other palpable lymph nodes. He had heterogeneous, mildly enlarged thyroid enlargement. Fiber optic scope showed right immobile vocal cord, left mobile vocal cord, and patent airway with no obstructions or masses. Then TSH was sent and it was normal. Ultrasound neck showed the right hypoechoic lesion with tiny hypoechoic foci measuring 2 by 1.5 by 1.7 centimeters. And the left lobe had a subcentimetric hypoechoic nodule. He had multiple abnormal bilateral cervical lymph nodes containing also the tiny hypoechoic foci. Overall, they looked suspicious. The largest was on the right side, 9 millimeter, and the left side is 1.5 centimeters. So we did a CT neck for this boy. So as you can see, the patient had a large thyroid mass that was encasing the innominate artery, subclavian, and common carotid arteries were surrounded by the tumors. The prevertebral fascia was spared. The esophageal invasion could not be ruled out when the radiologists were assessing the images. He also had multiple.
So this is what we are seeing here, Shada. I'm sorry. So you're seeing, if you can just describe the CT scan here. Do you hear me, Shada?
Yes, I can hear you.
Okay. So this is the mass.
Yes.
Chada?
Yes.
Yeah,
Yes.
you want to describe it?
Yeah, so this is a enlarged thyroid with invasion, with encasement of the innominate artery, and there was also, it was surrounding the common carotid arteries and subclavian arteries with multiple pathological looking lymph node. The esophagus, the radiologists were not 100% positive if it was invaded or not. The trachea was compressed, however.
Okay.
So we did an FNA as expected from the thyroid nodule, and it came back positive for medullary thyroid carcinoma. So what would be the next step for this patient? Would you send him to surgery? You will start a new adjuvant therapy. You would send for RET, oncogene, calcitonin, CEA, or you will send him for tracheal stent or tracheostomy first. And the poll is going on now. Okay.
So just give a few seconds for people to choose. We have 11 people. Okay. So let's see what people choose. So this is the choice. Maybe now we can get our panelists to comment. Christine?
I think before we do any surgery, we certainly need to have plasma urinary metanephrines before we do any surgery. I think red oncogene testing will be important. We have pathological confirmation of medullary cancer, but that is something that can wait. Calcitonin will help confirm the diagnosis. I think NIFA will be better to comment on. This is extensive in a young patient. Certainly in the UK we have less experience with neoadjuvant treatment, but I think there are some nice data coming out now. So I'll hand off to my colleague who is much better versed at answering that than I am.
Yeah, I'm coming to NIFA. So NIFA?
So this is very interesting. This 13-year-old boy, I guess going back to the beginning of the case for a second before we answer your question, the boy was short of breath and in the hospital and coughing for a long time, right? Is that how he presented? So I'm trying to think how they ended up calling endocrine, right? I think there were a few steps there that happened that just for my interest, like how did you get involved? If they were, I guess when they were doing a bronch on him or something and they saw the vocal cord, so they called you?
Actually, when we had the biopsy for MTC, they told us.
They did all that. Oh, fascinating. Okay, so if the boy is, first of all, the boy has to be clinically stable, right? He's a 13-year-old. If you're admitted as a 13-year-old, if you're admitted to the hospital with a cough and shortness of breath, this is more than just from your thyroid mass, right? So whatever it is needs to be clinically stable, right? So I would talk to the team and say, this, unless there was something I'm missing in the case, this is a patient who has newly diagnosed medullary thyroid cancer in a kid, but they're very symptomatic. So I need my head and neck surgeon and the pulmonary team. Let's figure out first of all what's going on and why they're doing this. And when they stabilize, I'm happy to do a lot of this outpatient, right? At least that's how we would do it. We would do most of this outpatient. So now assuming the boy is stable clinically, the issue is he has a new diagnosis of medullary thyroid cancer. 25% of the time it's hereditary, so that's why Dr. Christine was saying we need to do a RET proto-oncogene, right, to figure out if this is hereditary or not. Now that's going to take time to come back. In the meantime, the boy is symptomatic and has an invasive tumor, and so there are other things like Dr. Christine was mentioning. Let's make sure in case he has MEN2, right, and has a pheochromocytoma. I'm assuming that Professor Shaga would have told us if there were MEN2B features, like marfanoid features, neuromas. You get a history, did the kid cry as a baby, right? Lack of tears is suggestive of MEN2B. You look at their tongue, do they have any neuromas? You're looking for MEN2B features, right? Those are things you can clinically diagnose. In the meantime, you're also, the most common for the most common familial is MEN2A, and they don't have physical features, so you're gonna do plasma metanephrines or urinary metanephrines. For us, we do plasma because it comes back faster. but it doesn't matter which one you do. Make sure they don't have a pheochromocytoma and measure their PTH and their calcium. Make sure they don't have hyperparathyroidism while you're waiting for the RET. Then you're talking to your surgeon because the best chance of getting rid of this disease is surgery, right? And the baseline calcitonin and CEA, this is where it differs a little bit from differentiated thyroid cancer. Differentiated thyroid cancer, there's controversy about whether you do TG at baseline with an intact thyroid. With medullary, there's no controversy. You would need a baseline calcitonin CEA because if it's higher than 400, then you're going to do distant metastatic imaging, right? So you're going to look at the rest of the body to see if that medullary is elsewhere. And potentially, is there something in the lungs going on, which would be unusual, but if medullary has gone to the lungs, you know, is there distant disease? Beyond that, the reason for these lead-in questions of 1, 2, and 4, well, 4 was because of the breathing, so we need to talk to pulmonary and figure out what's going on, and or head and neck surgery. If you, while you're waiting for your RET proto-oncogene, rather than, and you've ruled out, let's say, pheochromocytoma and hyperparathyroidism, right? If he doesn't have a pheo, he doesn't have hyperparathyroidism, the next question is, what's the next step in the treatment of the medullary thyroid cancer? And ideally, similar to the last case with the pituitary, that discussion with the surgeon is, does he have, he won't be able to take this all out and have clean what's called R0 margins, right? So is there something that could shrink it? Well, to do that, you need somatic testing, right? So genetic testing or molecular testing of the tumor to see, is there a target in that tumor that we can have a drug to shrink the disease first before surgery, right? Which is not in the guidelines.
Let Dr. Shada answer some of your question. I think she has probably answers to many of your comments, and I think that's excellent. We'll get back to you again.
So to give some context, he was admitted under pediatrics and was admitted under respiratory team who extensively investigated him. And then the last thing they looked at is actually his thyroid. And then at that time we were told he was vitally stable. So the autosat was normal on room air. He did not even require nasal cannula for that, but he had an audible wheeze. Sorry, stridor. So we did as suggested by Dr. Christine Bullard and Dr. Naifa Busaidi with the calcitonin level that came back high as 4,422. So logically, we did the metastatic screen with MRI brain, chest, abdomen, and pelvis, and they came back negative for malignancy. Remember, he's a pediatrics, and pediatrics do not like CT, so they chosen the MRI. The blood red oncogene was pending. It takes some time to get it back. So to buy some time, we did I suggested the 24-hour unimetanephrine, normetanephrine, calcium PTH, but they all came back normal. So what would be your option of management? So number 1, if germline red oncogene is positive, then start sulfacatinib neoadjuvant therapy. Number 2, consider debulking followed by external beam radiation therapy. Number 3, if germline RET is negative, do tumor biopsy and check for RET in the tumor. And then number 4, 1 and 3 are valid options.
Just before we take the polls, I just want to remind you that the CT scan is showing encasement of major vessels in the neck. So that's to be put in consideration when we manage this patient. Let's see what people think. All right, let's just give a few more seconds. All right, so the majority thinks that 1 and 3 are valid. So if germline red oncogene is positive, start sulfacatinib. And if germline red is negative, do tumor biopsy. Naifa?
Are you going to give us the answers for that? What were the testing?
Sorry?
Asking if she was going to give us the answer.
Yeah, she will. So,
no, I mean the test. Did the RET test show?
Shada?
So as I mentioned, the germline testing was still pending at that moment. And maybe some of the audience are familiar with the publication, the new adjuvant use of selective RET inhibitor, which Dr. Nafa Busaidi is one of the authors, as a new adjuvant therapy for invasive medullary thyroid carcinoma.
So Dr. Naifa is on this paper actually, so she must be very familiar with it. Now, this is the RET oncogen.
Yeah, so the germline mutation came back negative for this patient, which we did not really expect. He was a young boy with NTC, an extensive NTC, and we were quite sure that he will be RET positive, but he wasn't. So at that time, he underwent diagnostic bronchoscopy and esophagoscopy. The examination showed significant tracheal compression posteriorly with no visible mucosal invasion. The flexible esophagoscopy showed mild narrowing at the cervical esophagus, but the mucosa were intact. So we had this MDT meeting and family meeting, and after a long discussion, we decided that we will go for the surgery after the patient passed the carotid occlusion test. So in December, he underwent total thyroidectomy, central lymph node dissection, bilateral modified radical neck dissection, sternotomy, synthetic interposition graft of the innominate artery to the right subclavian artery, right common carotid artery ligation. And the tumor was shaved off the trachea with small remnant left over the medial aspect of the trachea and the esophagus. The surgery seems heroic, but we are blessed with amazing surgeons. And the boy was a real fighter. So, he was actually discharged on day 9 post-op, discharged home. Histopathology came back positive for medullary thyroid carcinoma with proliferative activity less than 3 mitosis per 2 millimeter cubic. He did not. He also had 14 out of 64 lymph node positive for metastases and with extranodal extension. Collectively, the patient was staged as T4A and 1B, and at that time we sent the tissue for genetic testing. So this is his calcitonin level. I will just remind you that preoperatively the calcitonin level was 4,505, and then 1 month after the surgery it was 752, and then 3 months post-op it rose to 1,700. And 3 months post-op, this is his PET-DOBA study, and as you can see, the trachea, the residual at the tracheoesophageal. Okay. So we will start with, So he has the tracheoesophageal groove residual. As you can see, it's lighting over here, and also in the second picture that you can see it. And also he has evidence of liver metastasis. You can see these black dots in the liver, also one in the mediastinum, and probably this one was also in the lung.
And his preoperative evaluation was negative for any of this, correct? So this is an indicative of a kind of aggressive disease.
Yes, so the CT neck, it showed the residual that was seen in the PET-DOBA was 3.3 centimeter, and it was inseparable from the esophagus. And there was no cervical lymphadenopathy. The CT chest showed multiple bilateral subcentimetric lung nodules. The MRI liver, as you can see here in the picture, that showed evidence of liver metastasis. This is 8 millimeter and 9 millimeter liver metastasis. So at that point, what would be the next step for this patient? Would you start cabozantinib or vandantinib, or you will send for external beam radiation therapy to the tracheoesophageal residual and observe the rest of the lesions? Or you will send for a gallium-68 scan, and if it's positive, then for PRRT, or you would need more information.
So let's see what the audience think, and then we'll ask Dr. Naifa to comment also. And Dr. Christie. So until we get more voting for this is a patient who has very aggressive, locally aggressive disease, a young boy, and now he is coming with metastases. And let's see what people think. So the majority will start this patient with cabozantinib or vandatinib. Nobody would give external radiation. Nobody would give PRRT. And again, almost the same number, 33% want more information. Christine, I know you don't deal sometimes with those very advanced cases, but we're going to ask your expertise here.
We discussed them in MDT. So did you tell us what the somatic RET
The
showed?
somatic RET was negative.
So both somatic and
Somatic.
Sorry, the germline was negative. The somatic, I did not tell it. I did not state it yet.
Okay, I'd like to know that, please.
Sure. So these came back positive actually for RET oncogene mutation. So we decided to start him.
Before that, Shada, let's see if Naifa would agree with this plan. Naifa, this is the situation.
This is a very rare, I know why you chose this case. This is fascinating. I mean, it's sad for the parents. It really is. This is a 13-year-old kid who's diagnosed with sporadic medullary thyroid cancer. I just want us to swallow that for a second, right? We all see medullary thyroid cancer every day, and so we think sometimes we just think these are normal. This is a 13-year-old boy and it's rapidly progressive, right? This is not a good thing, and it's highly unusual. So I also want to point out that the DOPA, first of all, Saudi Arabia, you guys are rich. This boy gets MRIs and DOPA PETs, and I don't know about the rest of you, but many places in the world don't have this many tests, so it's awesome that this boy had access to you guys and the expertise, and a pediatric surgeon who didn't cause this boy to be hypopara, right? The parathyroids are tiny, and he had extensive surgery in his chest, right? So this was a big deal. This was not an easy decision. I'm sure your team, you beautifully presented it like it was a 5-second decision, but I'm sure this kept you up at night, right? The other point is that this is why when people have this aggressive disease, if we can get a molecular testing early, right? Something fast, because all these tests take too long, right? I mean, nowadays, I'm thinking where we need to go for the future, because all the questions, these beautiful questions you're asking are not in the guidelines, right? What do we do with these cases? So like Christine was saying, we have to discuss this in multidisciplinary over and over again. So there is a rapid FISH test for RET that one can get access to. If you're thinking about if this patient has a somatic RET mutation, yes, meaning it's not in their blood, it's not hereditary, but they have the RET on their tumor, can we use a drug to shrink it, right? Which is where they were going with this. And so there's a blood test for RET 918, which is the most common RET mutation in sporadic disease. That it's called a liquid biopsy that you can look for, and if you have access to, or a FISH test. Otherwise, all these things take 4 to 6 weeks, right? And this boy was not breathing and harming. So yes, ideally, if you get somatic RET testing and it's positive, if you can use the drug even to shrink it before surgery, which is the paper you showed, so that surgery could be easier in this 13-year-old boy who otherwise has a lot of problems from this disease. The issue is that there's not long-term data in kids. Right? He still has to grow. He's 13. But you have a rapidly growing tumor. So these are just complicated discussions you're having with the patients, with the parents about this. Because if you start this chemo, do we really understand side effects, right? All the drugs that are, and patients are like, oh, well, chemo doesn't work in thyroid cancer. Any drug that's anti-cancer is called a chemo, right? And needs to be taken seriously. So while this drug in adults is known to do very well, there were some of the kids in the trials up to 12. So this boy was 13. So yes, I agree with what you said, somatic RET testing, and then consider selpercatinib, and the doses to be argued about. And the baseline CEA, I guess, was high. You did an MRI of the liver post, and it went from negative to positive in 2.5 months, right, or 3 months. This is bad disease, so I agree with starting a drug, and I'm really happy that he had a RET.
Based on a positive somatic RET mutation, then we started him on a direct RET inhibitor, selpercatinib. This was started earlier this month. The CEA before selpercatinib was 19, and then it went down to 11 within 3 weeks of starting PV therapy. Calcitonin is not yet out. It takes some time to get it back. The boy was tolerating it very well. He actually gained some weight. And our plan that if the calcitonin is reassuring, then the subsequent image will be in 3 months after sarcocatinib initiation, just to make sure that there's an anatomical response also.
I will just make a few comments here, if you allow me, because actually Shada was communicating with me on this patient. In the initial stage, we could have done RET testing very rapidly. However, the patient was really critically ill, and I think she chose to proceed with surgery because time was an issue. So that's one thing. The second thing, as you mentioned, Naifa, this is a 13-year-old boy. When Shada mentioned him to me, I thought Red would have to be positive, and I thought he would be one of those MAN 2B or 3, which frequently occur as a de novo cases. However, it was surprising that's negative. I think one still would have to consider the possibility of small deletions. Most of the mutations in MEN2 and familial medullary are point mutations, but there are some cases where they have deletion that may not be detected with next generation sequencing or Sanger sequencing. So we're working on that actually. And I think this, as you just mentioned, this is very aggressive in MTC in a very young boy, and I think silpercatinib hopefully will stabilize it. So it is really a very unusual case. This is why we are bringing it here for discussion. Any final comments on this before we move to the last case?
How he does.
I think that's
Yes,
and very
Christine.
well managed. A fascinating case, which was very well managed. So my question to Naifa is, if there was time, or if you could do one of those rapid tests for RET, you would have given him pre-op selpercatinib, neoadjuvant selpercatinib.
Be better done in a trial, right? In a trial, because this is still being investigated. So if there were a trial available, but if not, it would just be a very long discussion with the parents of the pros and cons and the unknowns, right? Just be honest with them. But I think that what we're showing so far with neoadjuvant therapy in the trial is that shrinking the disease preoperatively with the selpercatinib can pull it away off the carotid and the jugular so that you can get R0 resections. But the surgeries post-exposure to selpercatinib are tough. There's so much fibrosis there, and so you obviously have phenomenal surgeons, right? This patient did really well, but they knew going in he was going to have residual disease, even the best hands in the world. So ideally, if there could be something, yes, that's what we would do.
Yeah, that was one part of the decision, because the surgeon is an outstanding surgeon. So it was part of the decision to proceed because the patient was sick, and the surgeon is excellent. So overall, I think Shada favored to proceed and to avoid a complication. He was having stridor. He was about to block his airways. So I think that was the reason for proceeding.
Yeah.
Okay, let's go to the last case. We have maybe 10 to 15 minutes. This is a bit lengthy case, but it's also a fascinating case. She is currently a 67-year-old lady. She had rectal cancer at age 43 years. She underwent anterior resection and chemotherapy in Jordan in 2001. And then at 2009, at age 52 years, she was diagnosed with papillary thyroid cancer. She underwent total thyroidectomy. At that time, she was looked after by another colleague. In 2009, she underwent total thyroidectomy, and the pathology showed papillary thyroid cancer, classic type, involving the left lobe. The tumor was 4 centimeters in maximum dimension, no vascular invasion, no extrathyroidal extension, and the rest of the thyroid tissue showed just nodular goiter, and benign parathyroid gland was also identified. No lymph nodes. So this is a low-risk disease, T2-NXMX, stage 1 in a patient who is only 52-year-old. So I think the critical question that anybody would ask should we give this patient radioactive iodine or not? And let me take your opinion on this. So again, this is a 52-year-old who had papillary thyroid cancer. Yes, it's 4 centimeter, but it's completely intrathyroidal, no signs of invasiveness. Let's see. So, and this is back in 2009, where the practice was more proactive. So the majority wanted additional information. 36% will give radioactive iodine, 0 would not give. So everybody will give radioactive iodine or need further information. Naifa, briefly, would you give this patient radioactive iodine in 2009 and in 2024?
So, like you said, 2009, very different, but I'm like the number 3 people. What did the preoperative ultrasound show?
So the preoperative,
and the surgeons didn't
yeah,
even
show
try to
basically
send-
the 4 centimeter mass only, no lymph node.
Okay. And then the surgeon's eyes, just so that I explain what my thinking usually is that I talk to the surgeon and read the operative report because it's very usually helpful, make sure they didn't see any central nodes and they looked around. So if this is a 4 centimeter PTC, there were no known lateral or central nodes, I might even have had the discussion with the patient of a lobectomy. Now in 2009, we didn't necessarily have that data, but even if they had a total thyroidectomy, I wouldn't give this patient radioactive iodine. I would check a TSH and T4 at 6 weeks and check a TG at that time to make sure. But again, hindsight's 2020, right? 2009 was a different practice. The second thing I wanted to mention, this patient had rectal cancer, but I'm assuming I would have looked at the history and they didn't have like hundreds of polyps to think about familial adenomatous polyposis or some connection between colon cancer and papillary thyroid cancer. And she's disease-free 20 years later, which wouldn't have happened otherwise. So I think because the first patient's question is like, why am I getting all these cancers, right? They all come.
Right. Christine, would you give radioactive iodine?
Now, no, and probably in our center, this patient would have had a lobectomy. I think I would probably want a CT scan though of neck and chest.
Okay, so let me tell you more information. So the whole body scan showed uptake in the thyroid bit only of 0.4%. TG was low at 2.4, TG antibody undetectable and TSH stimulated. And an ultrasound at that time showed 9 millimeter nodule, hyperechoic in the left thyroid bed that was thought to be fat only. So essentially his ultrasound post-operatively and TG is really low and everything seems to be great. So I will repeat the question one more time with this additional information. Who would give radioactive iodine? Who would not give radioactive iodine? Right? Okay, so let's see if things are changing. So again, 30% will give radioactive iodine, but now the majority would not do that, and some needs further information. Naifa, you have now all the information you need. Would you give this patient radioactive iodine? And today, let's forget about 2009.
Yeah, I would not give radioactive iodine. So what you have here is you have a stimulated thyroid globulin of 2.4, which is nice and low, right? And your whole body scan, diagnostic whole body scan, which not everybody does, right? It showed a little bit of uptake in the thyroid bed. 0.4% is nice and low. I think the guidelines refer to less than 5% in most excellent surgeons' hands, which obviously you have. You want to see less than like 0.5%, right? So this is good. The ultrasound does show a little nubbin of tissue there. That may be a little bit of thyroid tissue. A lot of surgeons will leave a little bit of thyroid tissue there just not to, harm the parathyroids and the nerves. So this wouldn't bother me so much, but it still has to be classified as indeterminate response to therapy. But I would skip the radioactive iodine.
Christine, you agree with that?
I agree.
Very good. Okay. So this was in 2009. So the endocrinologist decided to give radioactive iodine. And I think maybe some of us would have done that in 2009, not today for sure. I think the majority would not give a patient like this radioactive. And if we do, we will give him probably 30 curie. Anyway, he had 109, or she had 109, and the post-therapy scan showed only thyroid bed uptake. You can see the pre-therapy scan here on the left side. We use I-123, and there's a little bit of an uptake in the thyroid bed. Post-therapy scan actually showed the same thing. The nuclear medicine physician commented that there might be another faint focus below this, but essentially nothing in the lung or the bone or anywhere else. And this is back in 2009, and you can see here the data. This is what happens over the years between 2009 and 2016. She was seen more or less yearly. Again, part of the old practice is to repeat sometimes the scans, and this was repeated again in 2010, to ensure that the ablation was achieved, and it was achieved. And then in 2015, TG was 3.5, so stimulated TG again. So this is indeterminate response, and a scan was done. So everything seems to be perfect, at least until 2016. And this is again the report of the scan in 2010, complete response or complete basically achievement of ablation. And this is one of the ultrasound that was done every year or other year. And again, it's only showing that hyperechoic left side nodule of 0.8 centimeter. So what would you do now? I mean, this is an indeterminate response. Should we just continue following up this patient, do a whole diagnostic whole body scan, give an empirical dose of iodine 131 as it used to be done in the old age? Should we get FDG PET scan or additional investigation? Let me see again what will be the situation.
Odin, can I make a comment?
Yes, please.
Not about the answer this, just going back, I don't think it was the wrong answer, even in 2024, to give radioactive iodine. I'm just saying, like, Christina and I wouldn't give it in our practice, but if you look back as a 4 centimeter PTC, it's still within the guidelines to give it, because most practices would not have had a diagnostic whole body scan, right? You and I have it, Ali, and maybe Christine, you do, but a lot of places you either make the decision to give iodine or you don't, and then you just have the post-treatment scan. So I just wanted to say that even though the three of us today wouldn't give iodine, it's not the wrong decision, and it's still within practice guidelines. That's all.
I agree totally. In 2009, I would have given it. In 2024, I would have advised against it, but I will not block it. And if the patient wants it badly, after discussion, I'll give 30 millicurie only. Okay, let's see what people think. In 2016, what should we do? Continue follow-up. You remember she has indeterminate response, and if imaging-wise, anatomically, nothing there. So continue follow-up. 31% wanted FDG PET. Again, Naifa, what would you do in 2016 with those information that you have here?
That thyroglobulin trend is very helpful, and comparing apples to apples, meaning looking at the thyroglobulin with the same level of TSH suppression. And the reason that's important is the patients come to you and they're like, oh my God, my thyroglobulin is jumping up, and especially your engineers, right? My thyroglobulin went from 0.2 to 2, that's 10 times, right? So it's important that we help control the anxiety of ourselves as well as our patients. So in this case, your stimulated thyroglobulin here is 3, is the highest you went, and the suppressed is 1.82.
It's 0.6 and 1.8.
So it's a very low level of thyroglobulin with essentially an ultrasound that basically doesn't show. I mean, they have an 8 millimeter thing. You tell the patient, I don't know what it is. He doesn't even necessarily meet guidelines to get a CT chest, unless you were suspicious that this pathology was poorly differentiated, which we have no hint of that whatsoever. And we're how many years out?
This is now 7 years. 7 years later.
I agree with the audience. I just would do continued observation. The people who voted for PET, first of all, I think it's because it's Ali Zahrani presenting, and everything he's presented so far has been strange and aggressive. But also they have money, right? A PET CT is indicated if your thyroglobulin is greater than 10, or if you have a poorly differentiated histology. So just to point that out.
Let me show you. So I was not looking after the patient at that time, somebody else. This is the scan that was done there. No, this is the FDG PET. So the FDG PET was actually negative, but the FDG was negative. But on the CT scan, there was a small, non-avid right lung-based pulmonary nodule, indeterminate, and needs correlation with diagnostic CT scan of the chest for better assessment of both lungs. So the endocrinologist, based on this, went ahead and did CT scan. And this is the CT scan. And what you see here is really small nodules, non-specific nodule. But I want to show you the main finding here. Yes, this is the main finding. This is the nodule that was seen on PET scan and confirmed on a former CT scan. And the report of the CT scan is actually reporting more than this, reporting this as the biggest thing. It's 6 millimeter, but also reporting bilateral subcentimetric lung nodules. As you can see here, there are multiple bilateral subcentimetric lung nodules. The largest is 6 millimeter, and that's this one. Okay, so let me tell you what happens. This is in 2016, and you can see with further follow-up of the patient, the TG starts to go up. So again, the anxious endocrinologist in 2017 was worried about the patient and did scan. And this time the thyroglobulin has gone up to 15.1. It was last time 3.5. So now we are building a new story, I think. And he did the scan, and the scan this time came back positive, but actually not very impressively positive. Let me show you. This is the SPECT. And they reported about these two nodules here in the right upper neck as possible lymph node metastases. And this is basically the report, right upper neck, two small iodine aphid lymph node posterior to the right submandibular salivary gland, worrisome for metastasis. And again, the endocrinologist was so anxious about this, and especially it is now positive on scan, and went ahead and gave a second dose this time of radioactive iodine. This time is 218. You want to comment, Christine or Naifa, on the management at that time?
So those lung nodules did not light up in the whole body scan.
Here you mean?
Is present on the
SPECT
CT scan. They were not present on the SPECT CT by the looks of it, right?
Yeah, this is the
Oh, in the lung, the ones in the lung.
In the lung, no, it didn't show up at all.
It didn't show up.
I mean, this is the lungs. There is some background activity, but I don't think they reported it as negative. Basically, they did not report it.
I think that's interesting because you had CT scan findings that might have suggested metastatic disease. So I think a few comments. So that thyroglobulin is doubling within 6 months on two separate occasions, if I've got the dates right. So to me that is worrying. And I think in our center this would probably also have been treated with a therapy dose of radioactive iodine.
Naifa?
So can you to go back to the diagnostic scan report? So the the report, right?
This is it.
Neck lymph nodes posterior to the right submandibular. And what happened with the lung nodule did not light up or did?
No, it didn't light up.
Okay, so a couple of things. So those things, I mean, I would need proper cross-sectional SPECT. I know you can only show one slice here. I don't think those neck things are metastatic disease, but maybe I'm not seeing the picture correctly, because you can have uptake in your salivary glands, right? So it's important you look at your own scans when people mention, because people talk about if there's liver uptake, these are liver metastases, and usually it's just circulating thyroglobulin. So these might just be, anyway, we'd look at, these might just be salivary glands rather than metastatic disease. That's the first thing, because you had a CT scan that didn't show that. The second thing is, patients worry, oh my God, I have all these lung nodules, I have lung cancer, or it's spreading. And the point is they never had a CT chest to be ever, right? Not that it was indicated 10 years ago or 8 years ago. Nobody's saying anything was done wrong not to have a CT, but it's important that we tell the patient that, hey, this is your first CT chest. These lung nodules could be because you inhaled bird poop or fungus or granulomas in general, right? Or they could be thyroid cancer because your thyroid globulin is rising, but we don't know that for sure. Right? These are too small to biopsy, so we don't usually biopsy them. But the stimulated thyroid globulin went from 3 to 15, as both professors had pointed out, right? So the question is, are these thyroid cancer in the lungs, and is there anything in the neck? I'm assuming the CT neck you said didn't show, it just showed that little thing, yeah, that 8 millimeter thing. So we don't know. We can say we watch it aggressively, meaning we watch it as if it is thyroid cancer, but we don't treat it unless we're sure. And we don't biopsy it to be sure. Time is the only thing that's going to tell us, right? Because these lung nodules are not going to cause symptoms right now. It's the first time. So I would probably repeat imaging in 3 to 6 months, right? The guidelines, I think, say 3 to 12 months. Definitely suppress the TSH as has been done and follow this patient. And I probably would order molecular testing for future, not because I need it now, but just thinking about the future. Because it takes so long to get it.
Okay. Let me also show you the post-therapy scan. In fact, the post-therapy scan with 218 MCI did not show anything. I think I could say that this dose was given for what used to be called TG positive scan negative or biochemically incomplete disease. I think basically the endocrinologist was so anxious about this, and I think he has some grounds to do this. The positive scan, although it's questionably positive, the lung nodules, at any rate, it was given, whether it was appropriate or not. But let's proceed and see what happens. So you remember the 15. By the way, the colon cancer issue is in remission. See, so those nodules, you may think that this might be related to the colon cancer. The CEA is normal. The colonoscopy is negative. So it's not, and the liver is fine. So this is not colon cancer. This is, if anything, it's thyroid cancer. And you can see what happens over time between 2017, 2021. TG continued to go up. Again, he had another scan in 2019, stimulated TG 70. But even when the patient was put back on thyroxine and TSH got suppressed completely, the TG continued to rise. So I think now we have a real story here. And as Christine mentioned, this is quite worrisome. However, his diagnostic imaging continued to be more or less negative. The yearly ultrasound showed only that nodule and an FNA was done. It was non-diagnostic. He had MRI of the spine, which was negative. CT scan showed slow increase in the lung nodules from 3 to 6 millimeter maximum. And FDG PET showed no FDG aphid disease, but on CT scan lung nodules. Now, in 2022, the TG now suppressed, went up to 300 and 220 negative TG antibodies. And this is a CT scan, and I think now you can see clear increase in the nodules. So you can see a lot of nodules in the background. You can see here a intestinal mass of around 2 centimeters, and another one here posterior of 11 millimeter. And you can see the background of the lung is full of micrometastases. This is a 13 millimeter in the hilar area. And you can see here, you can see here a very clear metastasis, macrometastasis this time. And as we go down, we will see that big nodule in the lower chest getting bigger and bigger. Oh, I'm sorry. You can see this one, the small one that we saw earlier is now much bigger. So I think the story now is making sense that this patient is having recurrence and progressive disease and metastatic disease. And this is basically the report, enlarging right paratracheal and subcarinal lymph nodes, suggesting metastatic disease, stable lung nodules, and then there was something in the T-spine, T7, This is a PET scan this time. If you remember before, the PET scan was negative, and now we have some positivity at the same place here. And I will just run this quickly for the sake of time. You can see an uptake in the hilar region, in the right hilar lesion. And then down. Interesting that the lung nodules are not taking up FDG. You look at this big nodule in here, it's not really FDG aphid. The disease that is FDG aphid is in the mediastinum. So this is a heterogeneous disease. You can see here also in the plain film. This is the MRI, and this time we have lytic lesion in T7. You can see it here. So the endocrinologist referred this patient for XRT. The patient received 5 fractions, and she also gave her zoledronic acid. This is a CT scan in October 2022. No recurrent tumor in the neck, despite the lung stuff. But they commented on something in the left middle cerebral artery at M1, and they suggested to do MRA. So the endocrinologist, so before we say what the endocrinologist say, let's take, I think this is hopefully the last question. What would you do at this time? Would you start lymphadenib, do CT guided biopsy and genetic testing, surgical removal of the hilar and subcarinal lymph node, or wait and see? Let's see what people would like to do. I know we are beyond time, but I think we have some technical glitches. All right, so let's just give a few more seconds for people to choose their answer. And I will ask you, Naifa, what would you do for this patient? So this is basically, most people want genetic testing. Naifa?
Yeah, I mean, I think this is tough, right, for a couple of reasons. So one is that, you know, at the time, just going back, at the time of, I don't know, the second or third whole body scan, I don't remember how many we did, I would have told the patient, listen, you have thyroglobulin positive, radioactive iodine negative disease. Anywhere you go and travel, tell your docs that so they stop doing whole body scans, right? Because for a long time, many years, that's all we had, right? You see a screw, you have a hammer or a nail, right? So you keep doing what we know, but you're resistant. So, and TSH suppression has helped these patients. So even looking back 5 years ago, I don't think I would have done anything differently than what was done other than the radioactive iodine. TSH suppression and observation to look at the growth of disease. Not the growth of the thyroglobulin necessarily, except that that dictates imaging. And you saw what they did in Saudi is they ordered MRI of the spine at baseline or somewhere in between, which was fascinating, right? And would not necessarily have been done, but was negative. So you know this is new disease in the spine, right? So a patient who has metastatic disease to the hilar lymph nodes and lungs and what was the third place? Oh, and the spine, right?
And the spine.
So you want to take care of what's clinically important. So that's why they did radiation. I don't know if the patient probably had pain there. And you don't necessarily do surgery, but I would have gotten the opinion of my neurosurgeon, right? Because you want to understand what are the risks if we just radiate this of fracture versus impingement of the spine. So that would have happened on the side. I would have taken the original tumor that we had, if we have that tissue. Many pathology labs get rid of tissue after 7 to 10 years. And it's been, what, 12 years for this patient? No, I can't do the math, but many, many years. It have to be a biopsy, which is why this question is being asked. And then what would you biopsy, right? Because I would ask if pulmonary can easily get to the lymph nodes here, because a bronch would be easier than a lung biopsy if they're small. But I think this one, you could reach. It's fairly deep, but I would, basically talk to interventional radiology. Is it easy to get that, or is it easy to get the lymph nodes to get biopsy for genetic testing for the tumor? I agree with that. It's not the wrong answer to get lenvatinib because many, many countries in the world don't have access to other targeted therapies, right? Even if this patient has a BRAF or something else, if you don't have the drug, people are like, it doesn't matter. Now, you can order the testing, but it wouldn't be the wrong answer to start lenvatinib. Now, I will say that the soft tissue disease responds very well to lenvatinib, and this patient has fairly small volume disease there. So I would talk to the surgeon. If the mediastinal nodes don't look threatening, and I know the lung nodules are not symptomatic, and the back was treated, I might continue TSH suppression and watch, but very closely, like 3 months. And if it continues
this patient Naiva is showing a clear progression. I mean, the nodules were very small. Now we are dealing with a spread, with increasing number, with increasing size, and with even extension of the disease to the spine. I probably would not wait and see because of these factors. I don't know what you think.
I'm actually making
Well,
the
I
point
think
to
the
see.
patient is asymptomatic.
You see?
Patient is asymptomatic, and I think that's what Naif is saying, that, it's not wrong to observe this because, often lenvatinib or other targeted therapies, the threshold often, certainly in the UK, where we're much more cash strapped, is if this patient has symptoms, because, what are we treating?
Okay.
Let's
Let's
see
see
what
what
Christine
happens.
said. I just want to add really quickly to what she's saying, because people, even wherever you are in the world, people love to jump to the systemic therapy. It's not the wrong answer. What I'm saying is if you're treating the symptomatic thing, which is the spine, and it took a few years for these lung nodules to grow, right? It's not the wrong idea. You went 5 years knowing she had lung metastatic disease. Remember that. 2017, 2022. So yes, it went to the spine, but none of the drugs we have today prevent that. Nothing, right?
Okay.
And so if we know, and radioactive iodine didn't prevent it, so if we treated the spine and we tell the patient, you're looking at systemic therapy, you can start talking to them and consenting them, but it would not have been the wrong thing. I don't think it's the wrong thing is what I'm saying. Oh.
Let's see what happens. The endocrinologist, interestingly, discussed with the thoracic surgeon, and they decided actually to remove the hilar and mediastinal lymph nodes with video-assisted transthoracic surgery, which seems to be an easy procedure. Now, whether we agree with that or not, the procedure was done, and the patient had this removal of the paratracheal lymph nodes and had even lung metastatectomy of 2 or 3 nodules. And the pathology just confirmed now that this is papillary thyroid cancer. They did not actually in any way commented on poorly differentiated or high grade. As you can see here, it's basically metastatic papillary thyroid cancer, 1.5 from the right lung, another metastatectomy of 2 centimeter, and then fragments of lymph node with metastatic papillary thyroid cancer with extranodal extension. So for the sake of time, let me proceed. You remember that CT scan of the neck that showed nothing but left middle cerebral artery may have some prominence, and the radiologist recommended MRI. So that was done. The treating endocrinologist wanted to clear her by neurosurgery for possible TKI because of this incidental finding on the CT scan. So the neurosurgeon suggested to do CT brain with and without contrast, and the CT brain is showing brain metastasis. You can see 2 of them here, and you can see multiple small cerebral metastases, no significant mass effect, needs MRI, incidental left middle cerebral artery aneurysm that is very small, and they are saying the risk for rupture is very, very, very small here. So MRI was done, and you will be surprised to see something there very, very significant. So this is the MRI, and you can see a big metastasis here in the occipital region. In fact, it may not look typical metastasis. It's cystic. There is what looks like a ring enhancement. We have additional nodule here and there. And then as we go up, we see another small ones here and there. And then we have a big one in the frontal region here. So this is now a different story. And this is the report. There are interval of multiple various size hemorrhagic and necrotic metastatic lesions involving the supratentorial brain parenchyma, the largest of which in the right frontal lobe and measures about 3.5 by 3 centimeter. And there is a vasogenic edema and a mid-line shift of 9 millimeter and partial effacement of the lateral ventricles and subphalangeal herniation of the left. And there is a small microadenoma, a microaneurysm. The patient at this time is complaining of severe throbbing headache, projectile vomiting, blurry vision, vertigo, ataxia, inability to walk, and periods of presyncope. Her examination showed normal motor and sensory function, but she has ataxia and papilledema. I will just ask here, what should we do at this time? We are almost closing the case. So here you can choose more than one thing. Start with dexamethasone, emergency, craniotomy, lymphadenant. Don't resuscitate. What is the genetic profile? External radiation, barcodes? I don't know. We'll just take this question. I know we exceeded time, but just bear with me. This is coming to an end. So, Naifa, you may comment on the situation now.
Number 8 is the best answer. No, we actually, so just really quickly, a comment is that in anybody that you're thinking about starting systemic therapy on, always do a baseline MRI of the brain to look for asymptomatic brain mets. Remember the literature that we don't know what the true incidence of brain metastases and metastatic disease is. So most of the literature says 1 to 6% of the time you'll find brain mets that are asymptomatic, and so it's not necessarily in the guidelines to do a brain MRI, except before and on therapy, and if you're switching therapy. So in this, and oftentimes when you do that baseline MRI, we have a study that shows about 20 to 25% of the time in these advanced cases, you'll find brain mets. The vast majority are asymptomatic, okay? So for it to be symptomatic and big like that, number one, they definitely need multidisciplinary care, so you're going to have them see the neurosurgeon, the radiation oncologist, and first of all, you want to question, make sure it's thyroid cancer in the brain and not some infection or something else, right? Because these are really big and cystic, so you want to have a conversation, and whether surgery makes the most sense, or do you, there's multiple of them. Obviously, you can't get them all, but the bigger ones, because they're symptomatic, need surgery. And they have randomized controlled trials looking at stereotactic radiation pre-op, followed by surgery. So it's a very complicated case, and it's not an easy answer. So I love number 8. I do not know.
Very good. Christine, do you know?
No, I'm afraid I'll have to concur. My answer is also number 8. I agree with everything that Naifa said. I suppose they will need some steroids, and we may consider taking some of them out surgically, but.
So this is what we did. We consulted the neurosurgeon and said, no surgery, start dexamethasone. As usual, neurosurgeons don't see the patient, they see the MRI. So they said, start dexamethasone, put the patient in Kibra, consult oncology. So that was done, but the patient was not doing well. She was actually showing signs of herniation. So we took to two more neurosurgeons, and both of them said no surgery. And we were stuck with a patient who was relatively young. So we talked to a third neurosurgeon who was nice, but he said he's going on leave and will operate on her when he comes back. So the poor endocrinologist, said, that's too nice of you, but she will not wait for you. She will die before you come back from your vacation. So he was still nice and say, I will talk to my colleague to help. And his colleague was also nice and agreed to operate. So the patient underwent craniotomy and resection of the frontal and occipital tumor without complications. And this is the pathology. I'm sorry. This is the pathology, is basically metastatic papillary thyroid cancer from both regions. The BRAF immune staining was negative, and they did some additional staining, and nothing was really important. The patient felt much better after surgery. Immediately after surgery, headache disappeared, no neurological deficit, which was surprising. So the question, what should we do for this patient with lung, bone, and the remaining brain metastasis? And again, for the sake of time, I'll just show you what we did. So this is now the genetic testing. She has NTRK fusion protein, in addition to P10, TP53, MSH3, but we were happy to see this one here, the NTRK1 fusion. So we started her on lymphatin on larotrectinib, but as usual, things get complicated. So before we start, she developed bilateral DVT. We inserted IVC filter. She developed VE despite IVC filter. We treated her with low molecular weight heparin, and we started her larotrectinib, 60 milligram BID, then 100 milligram BID. She tolerated the drug well. She developed transient neuropathy that remitted completely with holding the drug for a couple of weeks. She is now on larotrectinib, 100 milligram BID. Her follow-up CT scan showed basically that the tumor shrank big time. Actually, we don't see tumors. We see post-operative changes only. You can see this one here. You can see edema here in the frontal lobe, and also some edema in the occipital lobe. But those small metastases are hardly seen. And the patient is doing well now, around 6 months, 5 months after surgery. So this is the case, and I look for final comments from Christine and Naifa. This is actually a follow-up CT scan that was done only 6 weeks after larotrectinib. It's still showing some hilar lymph node, but they seem to be less active than before. She is due for CT scan and PET scan soon, so I don't have a full follow-up on her lung metastasis, but the patient clinically is doing great, and brain-wise, she has lost most of those brain metastases. So, Naifa?
This is awesome. That's a beautiful case, really nice story, and tells me two important things. One is when that patient presented to us in 2009, never tell them they're not going to die of thyroid cancer. That is the worst thing you can tell a patient, and way too many doctors tell patients that, right? Number two is that genetic testing, the somatic testing of the tumor is very important when somebody you think is potentially going to need systemic therapy even in the next 2 years, right? So this patient, when had 2017, 2022, whatever genetic testing you could get on the patient would be very helpful, because NTRK inhibitors, RET inhibitors, and BRAF inhibitors can do just this. You save this patient from whole brain radiation, right? This is phenomenal. And so if you didn't have that genetic testing, you would have gotten lenvatinib, they might have had a bleed in the head, right? I mean, there's some data now that you can use lenvatinib in those cases, but I'm just saying that this advocates for that, especially if you're in a place where you can have access to these drugs, which you're, very lucky, right, that you have them. So those are my final comments.
Thank you, Naifa. Christine, final comment?
Yeah, I think fascinating case, luckily unusual behavior of papillary thyroid cancer, but highlighting all the various new options that we now have for patients. But I would like to emphasize, like Naifa, early genetic testing and then looking what is there in the arsenal. And that's an arsenal that keeps changing on a 6-monthly basis, I would say, with new data that are coming out and new trials. So I agree. Don't tell them, you'll never die from this. This is benign. This is nearly benign disease. Everything will be fine. I think that is wrong. Luckily, this is rare, but I think medicine has advanced quite significantly, and we can offer a lot of therapies for these patients.
Thank you so much, Christine and Naifa and Shada and Hissa. I think we had a wonderful session. I know we exceeded our time, but I think it's worth it. And apology for the technical issues that happened in between. Thank you so much. I appreciate all the input. This was very teaching to me personally, and I hope for the audience. And with that, we conclude. Thank you so much.